Fine.
Okay, great.
Oh,
Hey,
there's,
Town Point Two, if you want to give us like a 30-second heads up and then 10-second heads up, that'd be great.
yeah, our whole team is here. Paul just joined us, so we're good.
Okay, give us 1 second to go live and I'll let you know.
Okay, great, thanks.
And who will be running the slides for Paul and for Bill?
Someone on our team will be doing that.
Okay.
You can begin when you're ready.
Okay, let me move my slide on over here for just a minute. Okay, you ready to go?
Yep.
So 3, 2, 1. Hi, good afternoon, everyone. This here is the October meeting of the Health, Aging, and Disabilities Committee. I'll be chairing it for this evening. We have a presentation on COVID-19, so I hope everyone is ready to pay attention accordingly because it is an important thing. At this time, prior to introducing the speaker, I'd like to introduce my colleagues who have joined me also. If I could have each one of you introduce yourselves, please.
Bud Friel, City Councilman, 8th District.
Rashima Dixon, City Council at Large.
Well, hang on. Thank you for joining us. With 3 of us, we do have a quorum, so we could kick this thing off. At this time, I would like to introduce the Community Mobilization Group that's going to update us on the status of COVID-19 here in the city of Wilmington. If you guys, I'm sorry I didn't ask who would go first in this, but please go ahead.
Yeah, I'll be going first. Thank you very much, Councilman Adams. My name is Henry Smith. I'm Henry Smith III, and I chair the Wilmington Community Advisory Council, which established the Wilmington COVID-19 Community Mobilization Initiative about 7 months ago. Some of you may know, but repeat for those who may not know, the Wilmington Community Advisory Council is a diverse group of state and local stakeholders that was created in 2016 to address youth gun violence based on the 2015 CDC report. The council serves as a convener, broker, and advocate for addressing some of the social determinants or the root causes of gun violence, such as toxic stress and trauma, behavioral health, unemployment, and neighborhood safety. It does this by bringing together community organizations and coalitions and connecting them to needed expertise and resources. In addition, it advocates for policy changes that remove barriers. The long-term intent is to harness the power of partnership to improve practices and policies that can have sustainable, positive impact on reducing gun violence and promoting opportunities for positive development among our young people and helping our communities to become more resilient. In keeping with our communities to become more resilient, in April of this year, the Wilmington Community Advisory Council was approached to mobilize our network of community partners created over the last 4 years to prevent the spread of COVID-19 in the city of Wilmington. And we had a particular focus on the African-American and Hispanic communities in Wilmington. At about the same time, the mayor and city council had created a task force to coordinate efforts in the city. We all agreed that we should join forces and thus the Wilmington COVID-19 Community Mobilization Group was formed. Using the collective impact model with the WCAC as the backbone, this group includes the United Way, the Latin American Community Center, Kingswood Community Center, as well as grassroots organizations, members of the faith community, and community coalitions across the city. Most members have been WCAC members for some time. The intent is to leverage federal, state, and other COVID-19 related funding and support to suggest relevant policy or legislation, to create greater awareness related to the COVID-19 crisis that can help city residents and neighborhoods, and advocate for increased testing across the city. Since its creation in April, the group has expanded focus to include neighborhoods in Newcastle County that surround the city of Wilmington. And we've made significant progress to date. We've continuously advocated for greater transparency on the COVID-19 testing data related to people of color in particular. So at this point, we receive twice monthly analyses from the Division of Public Health, which provides a more complete picture of the prevalence of COVID-19 in the city of Wilmington. And we'll be sharing some of that data in just a little bit. We've also gotten support from WilMAPCO with regard to the analysis by mapping the results for us to see visually the impacted neighborhoods. And we will also see some of that mapping tonight, I believe. The data plus the map that we will share help us to determine the priorities for which census tracts to recommend to the state, the county, and St. Francis Hospital for increased testing. And as I said, we're going to have presentations on this data shortly from Dr. Paul Silverman from the Division of Public Health and Bill Switek, who is with WilMAPCO. They will present the most recent data. But let me just continue with a few more points of the progress that we've made. We've developed strong working relationships with Newcastle County and the state to do pop-up testing sites in the high priority census tracts, in addition to the establishment of permanent testing sites at the state service centers and at selected Walgreens. We have advocated successfully to have at least one testing site in Wilmington for students and teachers who live in the city in preparation for the reopening of schools. We've been working with St. Francis to do pop-up testing in some of the hard-to-reach neighborhoods on the east side, northeast, west center city, west side, and South Bridge, with the intent to get testing on the block. We've been providing safe community outreach and sharing information to promote the participation in the screening and testing sites operated by the county, the state, and other health providers. We have launched a social media messaging campaign, I Choose, inspired by youth and young adults with the creative materials and videos for community partners and coalitions to use. And herein we have received positive feedback on the appeal of the messaging. And we will be doubling down on the message that the pandemic is not over, and this is important, it's not over, and that the safety precautions must continue to be followed. We are monitoring and advocating for efforts aimed at recovery and prevention of resurgence. And herein we receive regular briefings from Lieutenant Governor Bethany Hall Long on the governor's pandemic resurgence advisory committee. We have been advocating for more funding to provide financial relief for families who must miss work to self-quarantine and recover from the virus. And finally, we've been advocating with educational leaders on the need for community voice in the planning for school reopening. So those are the things, some of the things that we feel constitute accomplishments of the Wilmington COVID Mobilization Group. And now I would like to introduce Dr. Paul Silverman. He is an epidemiologist with the Division of Public Health, and Bill Switek of WilMAPCO. And Bill, you or Paul can start. I guess it would be Paul, because Bill, you've got the mapping, sharing the data related to COVID-19 in the city of Wilmington and in neighboring communities in Newcastle County.
Right. Thank you, Dr. Smith. If we can get those slides up now. I think it's the other slide deck. Thank you. And I'll just indicate when to proceed to the next slide, I assume. So before I begin, let me tell you that all of the data that I'm going to be presenting today is available on our My Healthy Community website. It's sometimes you need to be a little bit creative about how you select and present that data. And I chose to present information that's for you. I thought it'd be most useful to present it in a way that you probably wouldn't be able to see it easily on My Healthy Community, but I do want you to let you know that this is the source of the data and it is available to anybody who would like to go in and get it. This first slide is the weekly case rate since July 1st. And the blue bars represent the state as a whole. The orange bars represent Wilmington. And the height of the bars represent the cases per 100,000 people. And so in this, you're able to see what is happening over time since July 1st, and also give us a baseline, if you will, in our comparison with Delaware as a whole. And the next few slides are going to be organized exactly this way. The last time period is very small because it is a partial week. But you can see that beginning in July, the case rates in Wilmington were about the same as Delaware as a whole. And that situation changed in late August, when the case rate in Wilmington began to increase significantly. They increased throughout the state. As you can see, the trend line, if you will, in the blue bars, they increased especially in the Wilmington area, peaking around early October, and then since that time have begun to fall, both in Wilmington and in the state as a whole. There could be several reasons for this, and one of them can be increased testing, and so that's what's on the very next slide. So this is the rate of people tested every week, same time period. Again, the blue bars are Delaware, the orange bars are Wilmington. And once again, starting in July, testing rates were about the same in both Wilmington and in Delaware. Beginning in, we'll say, early August, the rate of testing in Wilmington began to exceed the rate of testing in Delaware as a whole, and that pattern has continued to present. So in part, one of the reasons for the increased number or rate of testing the increased rate of cases in Wilmington as compared to the state could be because more people per capita are being tested in Wilmington than in the state as a whole. But that's not the entire explanation, but in part that could explain some of it. Next slide. And the reason I say that is because one of our best indications of the extent of virus in the community is the percent of tests that are positive. So again, beginning in July, the rate in Delaware and in Wilmington was not that different. It fluctuated a little bit, but you can see that starting in early August, the rate of tests that were positive in the Wilmington area began to greatly exceed the state as a whole. And that pattern has continued through most of the fall until about early October, when the percent positive began to fall both in the state, but especially in Wilmington. So it does appear from these three slides that the Wilmington area did experience some intense viral transmission during August and September, but it also appears that that pattern has changed now, and the percent positive, the case rate have both fallen. I also thought you might be interested in some of these indicators by race and ethnicity, and so if we can go to the next slide. This is the case rate by race and ethnicity, and it's very clear. Well, a few patterns that emerge. One is that the difference between Delaware and Wilmington is not that great. So what's happening in Wilmington with respect to the rate of cases in African Americans, Hispanics, and Caucasians is about the same. But obviously, in the Hispanic community is experiencing much higher case rates than both the Black and the white communities. Next slide. One of the reasons for that could be that Hispanics are tested more, but this slide indicates that that's in fact not the case. This is the rate of persons tested by race and ethnicity. And you can see that first of all, again, the rate of testing in both Delaware and in Wilmington is about the same for each of the groups. But whereas we saw high case rates in the Hispanic population, we're not seeing appreciably higher testing rates in the Hispanic population. So Hispanics seem to be at greater risk of exposure to the virus than the other race and ethnic groups. Next slide. These two slides address the death rate by race. And the slide on the left is the crude death rate, and I'll explain what that means in a minute. But you can see that that in Wilmington, the death rate is a little bit higher for the white population than the white population in Delaware as a whole. And in Wilmington, the white population has a higher death rate than the Black population. However, one thing that we worry about when we look at death rates is the impact of age. And that's because this disease is much more riskier for people of advanced age than people who are younger. And it could be that these patterns that we're seeing on the left result from the fact that the white population in Wilmington is just older than that in the state as a whole, or than the Black population. And that's why we look at the chart on the right. And these are age-adjusted rates. And through the miracle of statistics, we're able to eliminate this impact of age. And when we do that, we see very different patterns. First of all, the Black population has a much higher rate, both in Delaware and in Wilmington, than the white population. And you can compare the white population, for example, in Wilmington, compared to the Black population when we looked at crude rates, and now when we look at the age-adjusted rates, and you can see it quite a bit different. So what these two charts are suggesting is that even after you eliminate the influence of age, the different profiles that these populations have in terms of their age distribution, there is an excessive rate of a risk of death among the Black population as compared to the white population. The final slide I have addresses the Census Tract analysis that Dr. Smith mentioned earlier. And we were asked to develop a method to look at the priorities that among the census tracts, that was where should effort be addressed to offset the risk of transmission geographically. Before I talk to you about how we did this, I do want to mention that there is one column, it's the second column from the left. It says trend since previous data. Please just ignore that information. After we did that, we realized that we were comparing the rate of one time period with the rate of another time period based on cumulative data, and cumulative data never decreases. So that's why those are all positives. So we've discussed this internally. We need to go back to the well and look at another method to display trend. But for now, just ignore that column. The challenge for us was to find a way to do this where we would de-identify the data that is not display the data itself. And that's because at the census tract level, the populations are small, and our privacy rules require that under those circumstances, we not provide actual data. So we looked at three measures: the cases per 100 people, the percent of the people who are tested in that census tract, and the percent of people who were tested and were positive in that census tract. And within those groups, using actual data, not colors, we determined there are 24 census tracts. So we took the highest 8 and we made them red, the lowest 8 and made them green, and the middle 8 and they became yellow. And we did that for each of these 3 measures. That derived for us these colors that you see here. And then to get an overall priority, we said if there are 2 reds, that is if 2 of those measures are red, then the overall priority is red, as is in the case for census tract 25. If 2 of them are green, then it's green. 2 of them are yellow, it's yellow. And if there's 1 of each color for each of those measures, then we made an arbitrary decision that the percent of people tested who were positive would be the leading indicator for that particular census tract and reflect the overall priority. So that is how we have come up with a methodology to give the city some sense of where priorities are, and we provide this data every 2 weeks. So with that, I think now, Bill, I turn it over to you.
Thank you, Dr. Silverman. And if we can pull up that other slide deck, that would be great. Awesome. So my name is Bill Switek. I'm a principal planner with WILMAPCO, the Wilmington Area Planning Council, and I'm also a geographer by training. So when I saw that data from Dr. Silverman, the first thing I thought about was, man, we need to map this. And so what I did was created a very simple interactive map that's kind of a toolkit for the response group to look at and see where those census tracts are across the city in those different categories that Dr. Silverman described as the high, medium, and low. And so you can see those reflected on the map here. The Riverside area of Wilmington, Lower East Side, the West Side communities are in those red census tracts, and then the yellow communities, the Southbridge area, Christina Landing, Hedgeville, I can see here, are in those yellows, and then the kind of the northwest section of Wilmington is in green. And these have changed a little bit over time as those data have come in, and the group has reviewed this every couple of weeks to really try to identify places where testing can go and where increased testing can go, and also where outreach can be targeted for preventative measures. So if we can go to the next slide. This is one of the overlays on this dashboard that looks at where the recent testing sites have been, and these are pop-up sites. So the light gray circles are sites that occurred in September, and then the orange ones are those that happened in October. And then the blue ones with the medical bag there are the fixed testing sites that the states rolled out. So as has been described, what we're trying to do is look at where these high priority tracks are and make sure that we are recommending different testing that takes place there to really try to stay on top of the viral outbreak. If we can go to the next slide. And we've been doing this not only for Wilmington, but we actually have data for the entire state. And included in this map, sort of a map of Newcastle County, just part of the county at least, just so you can see that there are high priority tracks that have been identified in Newcastle County as well. And I can say that Newcastle County does consult with this data to select where those pop-up testing sites are occurring outside the city of Wilmington as well. If we don't update the map, I do get an email from them asking where it is. So I can tell you that they are definitely looking at this. Next slide. We've got a lot of other layers on this toolkit that the group considers when placing or recommending the placement of the pop-up sites. One of them is an overlay that we have at WMAPCO called our areas of social determinants of health concern. And these, of course, are the conditions that people are, that live through, born into, that affect health outcomes. So areas of lower education rates, lower incomes, all those things kind of go into making an area of higher social determinants of health concern. And you can see them outlined in both gray and black here, the gray areas being of medium high, and then the black areas of high. And what's fascinating is when you overlay this with the high priority areas in Newcastle County, you see really good alignment. So these were identified a couple of years ago by WMAPCO as areas, that have a concern for public health. And now when we have the pandemic, and you see where the areas of concern are, there's really good alignment there. Long story short, this data really helps try to target within those census tracts, those high areas where perhaps the pop-up sites are most needed to drive people to. Next slide. We've got some other layers on this map that the group considers, both for looking at where testing sites should be and also where additional outreach should go, and some considerations for that. So these are other data layers that I've built over the years. The light gray is looking at where there's concentrations of zero car households. So households that don't have car access. And again, those are in the lighter gray. And so again, when you're putting a pop-up testing site in that location, really good idea for that to be a walk-up site. So, it's not reliant on people having to walk some distance to get to it. The other layers show where we have concentrations of limited English proficient communities, so communities that don't speak English very well, and these are broken down into different language groupings. The red show our Spanish-speaking communities. So you can see sort of some alignment there on the west side of Wilmington, stretching out along the Kirkwood Highway corridor and so forth. Next slide. And then in addition to that, one of the new measures that we have is looking at where our urban technology deserts are. I was kind of looking at some census returns in Wilmington that prompted, going down the path to look at this data. But what's interesting is, there's really a digital divide in the city and also outside of Wilmington. When we look at who completed the census, on the Lower East Side, for example, less than half of people who completed the census did so over the internet, whereas in the Trolley Square area, it was about 95% of people did. So that really shows that computer access, internet access is something that's an issue. And what we're outlining here are those neighborhoods where the internet access, computer access is of concern. It's higher than what it is in the region. And again, like our limited English proficient identification process, it informs the outreach that should take place in these communities with related to COVID-19. And really any outreach should be more low tech, not reliant on internet-based outreach approaches. So next slide. That pretty much concludes this slide deck. So I'm just going to turn it back over to Dr. Smith to wrap us up.
Okay, Councilman Adams, do you have questions for us before I offer my summary remarks?
Sure, we could go around the questions. I think that would be fruitful at this point. Couple of graphs that you put up, the bar graph. Okay, it looks like you went from 3% to 4.5%. That's a 1.5% difference. But you said that was very significant. So what is significant to you? A half a point? How do you determine what's significant and what isn't when you're working with such a small variance?
I'm not exactly sure which particular graph you're speaking
You had
of.
some vertical bar graphs
Yeah. Let me
with the orange and the blue.
Right. Well, to answer your question generally, we're all kind of flying blind right here with this experience. I haven't done any tests of significance on this data, but it's really just intuitive. It's just, and the other aspect of this is we really can't look at the difference between 1 week and another in isolation because the situation changes so quickly. So we're looking for trends over time. So for example, when we looked at that case rate beginning in August, it was much higher that week of August 19th for Wilmington compared to Delaware as a whole. In isolation, we would note that. But what really makes it powerful information is when we start to see that again and again and again for about 6 or 7 weeks.
I saw where your testing went from like 2,000, 2,500 maybe to 3,750, about a 1,250 person difference. And that yielded perhaps 12 to 15 more cases. So I guess that would match your 1% increase. And so I can see where your data agrees with one another. I just want to understand the definition of when you say cases, new cases. Is that saying that they've contacted COVID, or does that mean that they need to be treated for COVID, or they're asymptomatic? Does that mean that they're going to be hospitalized? And can we correlate what you're calling caseload or new cases to outcomes in this case?
Yeah, all of the above, really. What our use of the word case means, someone would give positive tests. So that means that they could be anywhere on that spectrum of having no symptoms to being hospitalized and even died. So that's, I think, an answer to your first question. There is a correlation between case rates and hospitalization and death. That correlation used to be a lot stronger earlier in the epidemic. However, what we've been seeing in the past few months is that irrespective of increases in the cases, hospitalizations and deaths have not increased as dramatically as they did earlier in the epidemic. So that correlation is still there, but it's weaker.
Yeah, my understanding on a national level, those hospitalizations are down significantly, 60% or something like that. They're at 40% level where they were when the pandemic started. So, and the mortality rate of this, again, is age weighted, like you said in the very beginning, right? Now,
Go ahead.
How much of those changes in population are attributable to age weighted versus, like you said, ethnic background in this particular instance?
So age is most important when we talk about mortality, because the risk of dying from this disease increases significantly in elderly people. It's not as important when we're talking about the risk of acquiring COVID. It is a factor, but it's not as important. So whenever we display mortality rates, we like to show them as age-adjusted rates, as I did in that last slide with the 2-on-1 graph. There's value in looking at both. The crude death rates are important because that's actually what's happening. But in order to get additional insight into the risks involved from dying, apart from age, you need to age adjust. Hopefully I answered your question.
Yes, you did. However, you seem to jump from caseload to mortality here, and isn't the mortality rate of this disease still less than 1% overall?
Yeah, it's let's see, I have the
Because I saw a number like
You're asking-
0.3 or something.
I think you're asking for what is the risk of dying from this disease if you get COVID, I think is what you're asking about. And I actually haven't calculated that, but I suspect it is very low.
Yes. Yeah, and I understand nationally it is like a 0.3. Certainly you don't want to be age 74, which I think is the average age of mortality here. You better be 18, but we all would felt better at 18, regardless of COVID or not. No, certainly thank you for your presentation. If we do this in the future, if I may ask, that somehow you correlate your increase in caseload, or at least your caseload, with some type of outcome measurement, like, hey, was this percentage housewives, was this percentage, critical care, or whatever the case may be. So people can get a feeling like, hey, like I said, when you just spoke, you spoke immediately from caseload to mortality. And there's quite a range in there, especially if that mortality rate is 0.3%. That means 99.7% of the people get the disease, but something different happens to them. So I think that's important.
I think that is an important point, but here's something that's equally important. When we look at over 8 million people in the country having contracted COVID, that 3% is now translating to us to nearly 230,000 people. And so while the rate is relatively small, the numbers are great in terms of death, nearly 230,000. So I think we need to keep both of those statistics in mind as we look at COVID. I'm glad that the rate is low, but because the incidents are so high, over 8 million, when we take a 3% of that, it's a pretty large number.
Oh no, I understand that, but I think sometimes people aren't comparable. Like people always pick my grandparents' homeland, Italy. Okay, well, Italy only has 60 million people. We got 330 million people.
Right. So
the same percentage would yield a much higher number of people. And I don't think that those facts are ever, compared to one another. Hey, here's a country that has 1/7 the population, and that's 1/7 the numbers. And I don't think that that's it. Last point I'd like to make before I allow my colleagues to ask questions here. A lot has been emphasized about social interaction. And what I mean by that is the mask wearing, the social distances, the things of that nature. Now, when you say increase in case level, okay, how much can you contribute to that social interaction versus contagious of the disease in another way?
Well, I'm not exactly sure how to answer that except to say that I can tell you that this disease is transmitted from person to person. It all emanates from social interaction.
All emanates from social interaction. Okay, and so if you're measuring different demographics, do those different demographics have different social interaction that leads to higher numbers?
That's intuitive, yes. if you're looking at two populations and they have very different rates of illness, of COVID, it is because of the social interaction pattern differences between those two groups.
Great. Thank you, Doctor. You did answer that directly. And I'll move on with my questions. I'll certainly like to start. I see the Council President with us. Madam President, would you like to ask any questions? Ma'am, you have the floor. Oh, I thought she was on with us. I'm sorry.
I see her. She is.
Yeah, I was muted. Okay.
Oh, okay. Go ahead, ma'am.
Thank you. I said, forgive my cool glassware. And I just came from the eye doctor, so my eyes are still dilated and the light was bothering me. So I'm sitting in the dark with my shades on. But well, thank you all for your great presentation. And I thought it was very important that we got this to members of council, because even to your question, Councilman Adams, about the different demographics and their methods of socialization, I think every district has a different type of community engagement practice in their own districts. And so seeing that, and then seeing the what the percentages of testing or cases are in each council member's district, was hoping that they would assist, they could see where more efforts was needed to assist the efforts that are, people knowing where the testings are, making arrangements for them to get to the testing, or whatever we could do to provide the support to bring those numbers down if they're high in our demographics. And I did, from knowing of the knowledge of the data, it is high in some of our lower income neighborhoods. So I continue to always get good information from this. I don't really have a question other than what could we do as as council to assist to address the needs in the high COVID impacted areas. Is there anything we can do? I know we're working on communicating in various providing communication, whether it's the flyers that we give out to announce or through social media. Council members might have some unique ways that they communicate with their constituents that could be helpful to the group.
Was that a question or was that a comment, ma'am?
It was somewhat of a common question. It was a question that, is there something that that council members could provide or support the group with to assist them in helping to those higher impacted neighborhoods?
Got it. Well, thank you, Madam President. Does anyone want to comment on what Madam President had to say?
What contribution the council can make? I'd like to comment on that if I might.
Yeah,
sure.
Please.
Can I comment on it?
Yes, please.
Okay, but let me just go back to one question that you were asking Dr. Silverman, Councilman Adams, about the social interactions. And right. Dr. Silverman is the epidemiologist. I'm not an epidemiologist. And everything that I understand about this is that contracting the disease is non-discriminatory. It is caused by human interaction. That's non-discriminatory. Now, in terms of the impact of contracting the disease, that's influenced by other factors, including socioeconomic circumstances, the physical condition of the individual, and the level of treatment and care that they can receive. For example, Donald Trump contracted COVID-19. He received treatment that's not comparable to the kind of treatment that most people would receive. But that's a helpful element of his treatment. But I would go back to the statement that social interaction is common, non-discriminatory. Outcomes are based on differential physical circumstances and the ability to receive treatment for contracting the disease. What we are interested in is trying to limit, because we can't eliminate, but we're trying to limit the extent to which any individuals contract the disease. And here's where I think the 13 members of council, and you'll have 13 members of council can be of support to us in that regard. All of the council members, as I understand, are on our mailing list. So you receive all of the information that we get with regard to testing sites, the other data that Paul and Bill just shared. So we would be very much interested in having all 13 members of council participate in pushing this information out to your constituents, either through your neighborhood planning councils, civic associations, and other groups that you are aware of in your districts. The other thing that we would encourage is to have all council members walk the talk. That is, we would like for you to model the behaviors that we hope others will follow, which includes wearing a mask in public or when you're interacting with others, outside as well as inside. We would encourage you not to hold large gatherings that become unintentionally super spreader events. We would encourage that. And to the extent that council would be interested, there's always a need for additional resources to be invested in PPEs and community outreach. It's not terribly expensive, but it's something that council can certainly consider. And council has access to its public television station and whatever opportunities are presented to you to share the word that COVID-19 kills. It's a very dangerous disease. That would be extremely helpful to the work of the Wilmington COVID mobilization group. And I would thank you for your consideration of those requests.
Mr. Chair, may I?
Yes, ma'am. You still have the floor.
Thank you. Thank you, Dr. Smith, in that. And I think what I was trying to get at in asking was, we talked about it's a social contact disease. It's infected by people coming in contact with each other. And because of the different environments of our communities, you have some neighborhoods that when you come out, you can't do 6 foot distancing. If your neighbor comes at the same time you do, you're 3 feet apart from your neighbor. Okay, and in some neighborhoods, there are spaces from door to door. So with that type of understanding and differences, the people who live in that environment might have suggestions or ideas or solutions to address some of the issues that those of us who don't live in that same type of environment may have, which is why I was asking council to share what they might know works best in their unique neighborhoods that are on the maps in red and yellow for high concentration of infection or in need of testing. So that's what I was trying to get. So, because a lot of times, we make decisions, but we don't really, if you're not down in the neighborhood that where the infection is and with the demographics and the interactions, we don't actually know what best could work. So I was trying to get that kind of really hands-on intelligence to the working group so that we can take those facts into consideration as we're doing our work.
Thank you, Madam President. So I guess we need to go in order here. Mr. Phil, would you like the floor?
I just have a couple of quick questions. First of all, I want to thank you all for your work. I do review it every week when I get the emails from Gwen. But I just wanted some clarification, really. Trying to remember back to the charts, it seemed like the amount of testing has definitely increased over the months. But in looking at the one chart, it seemed like at least for the month of October, there appeared to be a decline now in the number of positive cases, both in Delaware and here in Wilmington. Is that fair to say?
You're muted,
Yeah,
Paul.
yes, yeah, that's an accurate statement.
Because when I follow the national news, it seems like there's a lot of states, a lot of areas going in the opposite direction. Of course, we're having more tests, but more positive tests. Do you think the message is getting out and we're starting, it seems to me more people are wearing masks and stuff like that than I would say this past summer when I was out and about. So I'm talking about, I guess, Wilmington, but even the state of Delaware. Do you think the message is getting out about how serious this is and in this for a long haul?
looking at the big picture, I would say that Delaware is faring better than a lot of states. Our rate of illness is high, but it has been not as high as other states, and it is not climbing as it is in other states. But it could be a lot lower, and there are a lot of states that have a lower rate. I think we're very pleased that we're not in the category of some of the extreme states, and we feel that part of the reason why that's the case is because the message is getting out. But there does seem to be a lot of community spread in Delaware, and that's something, of course, that we're uncomfortable with.
And then I just wanted to ask if Bill could clarify for me again, the chart that showed internet and computer. Can you just explain to me again, the dark blue areas, where I guess that was internet and computer. What exactly is the issue there?
So with that, I was looking at some data from the census that examined where we had concentrations of above average, or it was actually more than double the average of people in the light blue without both computer and internet access. The dark blue would be without household internet access. So you're looking at about, roughly 1 out of 5 people, up to about half of the population within that neighborhood without internet access.
So are you saying that it's not that they don't have internet service? You're saying in those areas there's poor internet service?
No, it's just that the household, when they did the census question, did not have internet service at their house. I don't believe it's an infrastructure issue. I believe it's a socioeconomic issue.
Okay. All right. Thank you. I appreciate that. And once again, thank you all for your work. I appreciate it.
Thank you.
Oh, thank you, Sarah.
Thank you, Mr. Friel. Ms. Dixon, would you like the floor, ma'am?
Yes, Mr. Chairman. Thank you. So I just had questions. One, I do want to applaud the work that has been being done over the course of time, and getting out the testing and tracking all this, because I know over the summertime, it was a really high period where we were really trying to concentrate on where we put testing sites and where the pop-ups, and a lot of the hospital systems coming around and do a lot of their testing as well. So I can understand why you would see Wilmington at those high points in August specifically, as we were, somewhat identifying that, there's larger areas that need to be tested, which increases the number of positive tests also at the same time. But I was glad to see that. I know what has been talked about a lot was that the African-American community was being hit more by COVID. And I was glad to see that there was an increase in the number of African-Americans being tested in the city of Wilmington. That was an area that we had talked about, I know, over the course of the summer to try to make sure we get folks tested in that space. So I'm glad to see that number of us getting tested is increased. I know you said it was more age range. Do you know what that actual age range breakdown is, Dr. Silverman?
For age range for?
I know you said the age as far as as far under the death rates, that is usually in the African American community is more age kind of driven. Do you know what the age range is?
The only thing I can say is that for irrespective of race or ethnicity, the older you are, the higher risk you are of dying if you do contract COVID.
Okay. And the reason why I asked that only is because I think that's also a case where we could push out more, right? If it's in a specific age range, to kind of say it can hit you just as much as it can hit a person who's in their 70s, right? So I think, us kind of pushing that too may also get more people tested. Because I know a lot of the schools are doing it now too, so that as students are starting to enter back into buildings. So I'll be curious to see also those numbers too, especially as our cases for the number of kids that are being tested and as well as teachers, staff, and folks that are coming in inside the buildings. And then I guess my other question is, I know that, and I also have been receiving the emails from Dr. Angela as well, but I also wanted to know, how could the public access the information, the data that was presented today?
Well, generally, I think, we have worked very hard to make our data transparent, and My Healthy Community is the source of that data. Now, admittedly, the data that I presented today, although it comes from that website, it's data that, because I wanted to compare two areas, I had to go into the data downloads and do some work in order to get it. So generally, the answer is My Healthy Community. For this specific data that I presented, these charts today, we have no plans to make that public, but certainly you're welcome to at the city level.
Okay, yeah, that would be great.
If I could also comment on that, we push the data that we get from public health every 2 weeks. We push that out to our mailing list of like 100 folks in the COVID group, and we say to folks, please share. If you got questions, let us know. So we're trying to do this in a way where we inform, but we don't terrify. In other words, we want people to have good information and then know what to do with it, as opposed to getting information and getting so fearful they don't do anything. So that's the balance we're trying to strike. So we're trying to use, the folks that are working in the neighborhoods as trusted ambassadors, if you will, to get that information out.
Gotcha. Yeah. And they have been doing that. So again, I don't want to discount that, but I just was wondering if the average Joe person was looking for it, how could they potentially do it? But because I know My Healthy Communities is the website a lot of times that has been pushed for a lot of the data. So as many people as we can get who are able to view this and see it and say, hey, this is where you can get the information, also as an organization of where you could get the information too, especially as everyone's applying for COVID dollars, that you could use that data to also apply it in those spaces as well.
Good point. Thank you.
Yep. And okay, because I'm like Sarah, I got a lot of questions. And then I know that I heard that there are someone was just recently telling me, one of the state reps was saying that there's been seeing a case of duplicates of people getting tested at multiple sites. Do you know if that's, Dr. Silverman, if that's a thing that's actually happening? So what I heard is that one person may go to 3 different sites and get tested like in the same day. Are we counting those numbers too, if that happens?
Yeah, so we present the testing data 2 ways, and I know this has been a bit confusing. We present it as persons tested. So if you're tested 50 times, it doesn't matter when, you're only going to be considered positive or negative based on that test. The other way we present it is as a duplicated count. So in other words, if a person who was tested today, even if they were tested 5 times before, would only be counted, would be counted today. Now, to get to your specific question, if we go through a process, we get, first of all, we get about 8,000, 6,000, 8,000 tests every day. And we have computer algorithms which go through those, and they look, sometimes we'll get the same test from a hospital and from a laboratory. Same exact test, it was only 1 specimen, but we had 2 reports on it. So we need to go through a deduplication process to eliminate those. Now, our algorithm does specify that if a person received the same test on the same day, they would only be counted once. So to get to your question, if somebody went to 3 different testing sites and got the exact same test, even though it was 3 different tests and it was on the same day, my guess is that they would only be counted once.
Okay, great. No, that's great to hear, because I think they were starting to be concerned that so many people, the person was going to multiple sites, and would they be, so if they're not, so we're telling people to be patient and wait for your results instead of going to another site, so that we don't have the duplication where we have to kind of go in and make those changes. So to the public, wait for your results, so that we don't have to go through the duplication process. But thank you, Dr. Silverman, that helps me out.
Yep.
And then my last question to kind of be somewhat of what Council President had alluded to earlier. I was just wondering, for Bill, what is, have you seen individuals change how they practice or their process based on seeing some of your mapping, especially around the places that have no car access? Are we seeing more testing sites starting to be more walkable in those areas? And then also, are we making sure that in the Spanish speaking areas that is being addressed specifically? And then have we seen people adjust their outreach process based on what Council President was saying too, based on where they are and if they, for internet access and what you had alluded to on the map?
Yeah, I think so, Councilperson. Early on, we saw an outbreak cluster. One of the red areas was in the Brandywine Hills area, and there wasn't any testing sites up there. And really because of the groups looking at those maps and, asking, for a site, we did get a few sites up there. So that's one example. And there have been others across the city going to different parks and so forth in those red areas. So I think people are taking note of it. And I know the teams that are out there doing outreach are also looking at those maps and particularly looking at areas where they're going to have to go in with interpreters with translated materials because you have a high Spanish speaking population, and it really wouldn't be of any point to not do that. So I think the answer to that is yes. Of course, it could probably be better, and there's probably more testing sites that we need to have. But the data are being consulted with where they're selected and with the outreach that is taking place. But yeah, there could be more testing and more outreach for sure.
Okay. Thank you. And I think too, it would be also interesting to see now that organizations are, especially the community health centers, are pushing more of the flu shots, that is still important to get your flu shot and your COVID test, and not do just one or the other. So I think that also would be useful, in conversations that we're talking about COVID too, and that we're not mistaking if you have flu symptoms that you may not have COVID. So just wanted to put that out there. But thank you all. That's all my question. Thank you, Mr. Chair.
Thank you, Ms. Dixon. Ms. Walsh, you have the floor, ma'am.
Thank you, Council Member. Number one, I apologize for being late. It's nice to see everyone, and it's especially nice to see my old friend, Dr. Smith. So I just have a little bit of a problem with some of the things that are being said today. I do agree with the statement that we don't want our citizens to be terrorized, but I also don't want them to be complacent.
Right.
And I think one of the reasons why our numbers did go down, number one, we weren't half the size of a state that we normally are in the summer because of how much our beaches were closed down and many of the shops down there even. So a lot of the ferry traffic and all the other stuff and all the out-of-state people that always came down there, whether it was for house rentals or for visiting. And the second thing is I just don't want those folks to start becoming complacent because things appear to be okay. Once things really start opening up is when all hell could break loose again.
Yeah.
And as somebody who is one of those who is a high risk, I am someone who listens to most things that are said to me. And all the time when people say, well, I need to come and talk to you in person about this, the first thing out of their mouth is always, well, I've been tested. And I'll say, yeah, but you've also been with 300 people in the last day. And you don't know how many of those folks have been tested. And, you know, this is kind of like what it's all about. And I think when we saw the numbers of the high areas throughout our section, I don't know how much this was touched on because I'm late to this meeting. But I think a lot of it also had to do with, if you took one side of town, there are a lot of parents who had the luxury of working from home. So they didn't have to pay for aftercare. They didn't have to pay for school in some areas. And they had the luxury of being able to take care of their own children. We have many other sections throughout town where people had to get to minimum wage jobs just to survive in their own neighborhoods. And they weren't able to get babysitters, and they weren't able to put in the effort that needed to be put in to keep kids off the streets. And many times we can't fault those folks because they don't have a choice at all. So I would just like us to be a little more careful than it kind of appears to me right now, because, you know, we have one airport that's very close to us, an international airport, meaning Philadelphia. We have another one that's not so far from us, meaning Baltimore. And once things really open up and all these flights start coming again, we're going to have a heck of a lot more people in this state, which, you know, we're going to wake up one day and it's not going to be here anymore. And that's going to be a terrific day. But as long as it's rising, what was it, 72,000 yesterday nationwide that tested positive? And as long as these things keep continuing, I just think we really need to be careful, and as careful as we can be. If I'm incorrect, let me know. You know, I've been correct a lot of times in my life, and this could be one of them.
You're right on point. You're right on point.
Thank you, Dr. Smith. It's good seeing you.
Nice seeing
Sorry
you.
you can't see me, but I'm not camera ready.
Very nice seeing you again.
Thank you.
Yeah. Thank you, Member Walsh. There appears to be no public out there, but I'll ask the question anyway. Is there anyone from the public attending who would like to ask the question? No, I think we're empty here. Do any council members have any additional questions for the panel? All righty. Well, hey, if that's the case, does the panel have any closing comments that it would like to make?
I think I've made my final remark was the request of you, but the responses that I'm getting from the council persons gives me great hope that you will continue to act as really, really good emissaries in terms of the interests of the COVID-19 mobilization group. There are individuals out there in our community who are still vulnerable, and roles that you guys can play are very important roles, and simply want to encourage you to continue to play the role as well as you have been. So thank you again for having us here to talk about this.
Sure. Dr. Smith, Dr. Silverman, Dr. Angelet, thank you very much. Mr. Schwenk from Wilmington, thank you very much for putting everything together for us.
Anytime.
Certainly appreciate your time, and guess we'll see you again real soon, won't we?
Yep.
Yes. Everyone, I'd like to entertain a motion to adjourn the meeting.
So moved.
Second.
Second. That's it. The meeting is adjourned. Thank you very much, everyone.
Thank you.
Thank
Yeah,
you.
have a nice night.
Thank you.